Hello, everyone. I'm assuming you can see my slides and hear me. Someone will tell me or text me if things aren't coming through okay. The nice thing about getting to do a lecture 3 times in a row is
Road.
that you don't really have to change it usually. And the lovely thing about teaching anatomy as well, um, is that the anatomy doesn't change. It's not like when you're going to a specialty of cardiology or neurology, and every single year you've got new information coming up. We've known as much about the anatomy of the human body for the last 100 years, and it hasn't really changed very much. Gross anatomy and the kind of major where the lungs are, where the heart is, that all stays very static over time, thankfully. So as to say, yes, thank you very much for asking me back. I'm going to try and relate some of the anatomy that you might be learning in medical school. And I don't know if you guys do cadaveric dissection or if you just have images when you're doing your learning your anatomy. But I'm going to try and relate some of the stuff you've learned in anatomy to the black and white and grayscale pictures you're going to be seeing with your ultrasound scans when you're doing the workshops. As mentioned, I work as a consultant mostly in intensive care, but I also do emergency medicine in Dublin, in Ireland. And I'll apologize in advance a little bit for my accent, which can be a little bit difficult for some people. And I have a tendency to speak very quickly. And believe it or not, this is me speaking as slowly as I possibly can. Okay, as mentioned, let me change my slides. There we go. As mentioned, you can see a lot of these videos, which are primarily anatomy ones on emergencymedicine.ireland.com. I haven't made any new ones in many years, but they're still all there and available to see. So, what are we going to try and understand when we're doing ultrasound? We're going to try, and one of the biggest challenges you have when you start using point of care ultrasound is trying to wrap your head around what you're looking at. Ultimately, you're trying to explore a 3D structure with a two-dimensional imaging modality. And you can get confused at times, and you can make the wrong conclusions. So, for example, look at this picture of Prince William. It looks like he's being very rude to the press, but actually, when you take this picture in 3 dimensions and you get it from two sides, you can see that he's not at all. And this was on the birth of his third child. So this is really important when you're doing ultrasound, is that you're imaging a 3 dimensional structure, but you're using a two-dimensional tool. And understanding all the anatomical relationships and what you're looking at will help you to understand things much better. Okay. What we'd love to see when we're imaging our patients is something like this. A real life, it's got depth, it's got color, you can see it all moving, but we don't get that. And when we're learning anatomy and we're imaging structures, we get things that look like this. Here we have a cadaveric heart on the left. It's dull and pink and very uninteresting. The one on the right is nice. It's a heart that's moving, but again, we don't get the same depth in 3 dimensional perspectives. It's hard to relate that heart that was beating before that we saw with these images, and it's hard to put those two things together. Tools like this one, this is actually a transesophageal echocardiogram simulator. It's an excellent tool. It can be really helpful in helping you orientate ourselves to what's going on. And that's really what I'm going to try and aim for, try and get you thinking in 3 dimensions. I would really love to get you all into a dissection lab with a cadaver, and then we could all correlate the anatomy that we're seeing here in the abdomen. We could correlate that then with what we'd see. We could ultrasound and see all the different structures, but we'll have to limit ourselves to what we can do online. Okay, and I think the closest we can get to the cadaver lab is probably going to be with some CT imaging. So these are all CT scans. These are 3 CT scans, and they're all going to illustrate the right kidney, but they're going to illustrate that in 3 different planes. And by planes, I mean the slices with which they're taken. And we'll talk a little bit about that. Here we have the right kidney highlighted in red in the transverse plane. Here we have it in the coronal plane. Here we have it in the sagittal plane. And you're probably going to see a little bit of this, me using my phone as the potential POCUS probe. So I use a lot of this when teaching POCUS just to talk about movements and planes and things like this. So in a transverse plane, you're taking a section this direction. You're like slicing my head off or slicing me straight down the middle of the body. When you're taking a coronal plane, you're slicing me this way or slicing across this way. And when we're doing a sagittal plane, I'm being split straight down the middle and you're looking from the side. Those are really helpful to understand the different planes of imaging. So now we're going to try and expand that to think a little bit about ultrasound. And there's multiple confusing things here, particularly because ultrasound, the convention for imaging is at the very, and hopefully you can see my mouse pointer up here. The probe position is always at the top of the screen. So it's always at the top and the image at the bottom. Even though in reality the probe might actually be on the side of the patient, the image is taken in a top-down fashion. So, for example, in the right upper quadrant view, if you're doing a fast scan and you're doing a right upper quadrant view, you'll get to see the kidney in a kind of a coronal plane, a slice this way. Um, but the image we get at the screen will have the probe at the very top, which means you need to do a little bit of mental gymnastics. So when we turn the image on its side here, that's more like what we should be seeing here. Now, I've actually turned it the wrong way around. The liver should be at the top of the kidney at the bottom. Apologies for that. But when you turn these round, you're imaging the patient from the side, so it would be much more understandable if you could see the image from the side like we do here. And again, this CT scan, this coronal slice of this liver and kidney, this area that we're illustrating with the ultrasound, this is what the ultrasound is trying to image. Let me go back one. Okay, we're going to cover the anatomy relevant to the kind of following three modalities of point of care ultrasound. We're going to talk about the fast scan, the focused assessment for sonography and trauma. We're going to talk about cardiac ultrasound or echocardiography, and we're going to talk a little tiny bit about thoracic ultrasound as well, if we get time. So let's talk about the fast scan first. So the fast scan is a moderately useful test in the right population, and I've heard it described as a gateway drug to point of care ultrasound. In other words, once you get the hang of the fast scan, then it opens up all kinds of other much more useful possibilities for ultrasound. The fast scan is the one that's probably been around the longest. It's the original gangster of point of care ultrasound, developed way back in the 90s. And it's all about finding fluid in the wrong place. Your question when you're doing a fast scan is there intraperitoneal free fluid? You're not really trying to visualize the injury itself. Your patient may have a liver laceration, they may have a splenic laceration, but you're not really that interested in visualizing those. You're trying to see the consequences of it. So when that liver ruptures or spleen ruptures, you're going to have lots of fluid within the peritoneal cavity, and your fast scan can help you see that. So it's a very simple type of a scan. Let's start, for example, with this. We'll call this, it's labeled, says LUQ in the bottom corner, but it's actually a right upper quadrant scan. When we look at the right upper quadrant view, we have the probe marker, and again, this is unfortunately flipped the wrong way around because I've moved from Keynote to PowerPoint and it's flipped all my ultrasound images. This is actually the feet end, this is actually the head end. Okay, so we're looking in this coronal plane. So if we have the ultrasound probe, we're placing it in a coronal plane. We're going to have the left hand of the screen is going to be towards my head, towards the cephalad direction, and the right hand screen is towards my feet or towards the caudal direction. And on this image, you can see the liver, you can see the kidney, you can see at the back a little bit of the spine. And what we're really interested in is this area here called Morrison's pouch. Okay, Morrison's pouch is an area, and we'll talk a little bit more detail about it, where fluid is most likely to develop in a scan. And it's one of these potential spaces within the body. A bit like the visceral and the parietal pleura is a potential space, so usually touching each other. If you get a pleural effusion, the two layers of the pleura separate. Morrison's pouch is a bit of a potential space because here the peritoneum is reflected back on itself, and it looks like a white line because the two layers of peritoneum are touching each other. But there's nothing intrinsically holding them together, and if there's a lot of fluid in the abdomen, those will separate, and you'll see some black fluid in between. So when we're imaging that right upper quadrant, this is like what we're imaging, okay? We've got the probe in this coronal plane, as mentioned before. You're going to see a bit of the liver, a bit of the kidney, and then this Morrison's pouch in between. So how does this relate to our CT scans? Remember, we image it like this with ultrasound. So this is the same ultrasound scan that we saw before. We have a little bit of liver here, so head at this end, feet at this end. We have a bit of liver, we have kidney. This is our Morrison's pouch, which is this little area in here. It's a reflection of the peritoneum, and if you get free fluid within the peritoneum, it's going to appear in that spot. Let's look at an example of free fluid. So let's say this man has been in a car accident. He's broken some ribs in the lower right-hand side of his body, and he's come in and his blood pressure is very low. You're worried about bleeding into the abdomen as the cause of his low blood pressure. You place the probe in the right upper quadrant, and you'll want to be imaging again in that coronal plane. You end up with a coronal slice ultrasound. It looks just like this on the CT scan. We're imaging from the right-hand side of the body. We're going to catch a bit of kidney, a bit of liver, and a little bit of that Morrison's pouch. This CT, I've flipped this ultrasound round so it looks the same as the CT. So you can see there, you're going to have kidney, you're going to have spleen, and you've got a little black line. See that little black line in there? That's Morrison's pouch with some free fluid. But ultimately, what we want to see is what we're going to see with our machines is we're going to see this image flipped around the ways. Even though we're on the right-hand side of the patient, it's going to look like it's coming from the other end because the probe always goes at the top of the screen. That's just the way they work. Here you can see liver, here you can see kidney, and the little black stripe that you're seeing there, that is free fluid within this area called Morrison's pouch. Okay. So the fast scan is all about trying to find free fluid in the peritoneal cavity. And as such, we need to have a little bit of an understanding what the peritoneal cavity is, where it lies, where fluid is going to collect. So the peritoneal cavity is highlighted here in blue, and the peritoneum does a lot of folding back on itself. It goes, let's say, for example, it comes all the way up around here, around the left lobe of the liver, and then it turns back on itself. And it comes all the way around here, all the way into this little recess, and then it turns back on itself. It does a lot of that. Fluid can effectively move wherever it wants in this space. So there's no physical barriers between the movement, and it can go anywhere within those spaces. But what we know is that fluid will always go to the lowest point. Gravity will have an effect. And if you're examining a patient who's lying flat on their back, and remember all of our trauma patients will be lying flat on their back, the fluid is going to go to the lowest part of this image. And if you look at where the lowest part is, you'll see it's just here, okay? This part is lower than this part. So this right-hand side of the image, between the liver and the kidney, this is Morrison's pouch. This is why you find fluid in there, most likely because even if you've got a ruptured spleen, which is way over here, because the fluid can move freely within the peritoneal space, it'll end up in the most dependent or the lowest portion. It's going to end up in Morrison's pouch. So that's why we focus on that area when we're doing our point of care ultrasounds. Okay, once you get enough fluid, so maybe a good example of this would be ascites. So someone who has very severe liver failure will develop very tense ascites. They can have 10, 15, 20 liters of fluid within their belly. Then the liver itself can get almost completely surrounded in fluid. Remember, it'll start in Morrison's pouch first, but it'll end up filling up the entire peritoneal cavity. There's a little area of the liver highlighted here in red called the bare area of the liver. So here's peritoneum in white all the way around, and then it folds back on itself, all the way around the liver, all the way up underneath the diaphragm, and then it folds back on itself. There's a little area of the liver not covered by peritoneum called the bare space, the bare area, and you'll not see free fluid above that. Okay, so this is a nice little plain CT scan. This is a CT scan of the abdomen, and it's in that coronal plane. Okay, so we're slicing in this plane, and I can scroll towards the front, and you can see the ribs, the sternum, the xiphus sternum, and as I keep scrolling towards the back, you'll start seeing some of the anterior organs in the abdominal cavity. You'll see the big triangular shaped liver here, and if I keep scrolling posteriorly, you're going to see something else come in. You're going to see the pancreas. You're going to see the gallbladder. If I keep scrolling towards the back, you're going to see our little favorite organ, the kidney, pop in. Okay. So the kidney's nice and bright there. This is a scan. It's timed to show contrast within the aorta and the kidneys. Here we can see the kidney. Very closely related to it is the liver. And when I say related, I don't mean brother or sister. I mean it's close by within the abdominal cavity. And we talk about anatomic relationships. That's what we mean. The superior relationship of the kidney is the liver. This is our Morrison's pouch just in here. So you can see we've come quite far back. We're already at the level of the vertebra, and that's where our Morrison's pouch. So free fluid, where we're most likely to see it, is going to be in this area. And we're going to have our ultrasound probe just here, scanning in a coronal plane through there to see it. Okay, so we can scroll forward. So even if the injury is anterior in the liver, so let's say it's way, way forward in the abdomen, as blood trickles out of the liver into the peritoneal space, it's going to dribble all the way down, and it's going to end up lying in this space here, just between the liver and the kidney. You'll notice quite nearby, if I come forward a little bit, I pointed it out earlier, this structure, the gallbladder. The gallbladder is a fluid-filled structure in the abdomen, and so it will look just like blood on ultrasound. And you'll see this tomorrow when you do your workshops and hands-on scanning. You'll see lots of gallbladders, and they'll be nice and easy to see because they're full of bile, they're full of fluid. You have to be careful not to mistake fluid in the gallbladder for fluid in Morrison's pouch, which is why it's so important to understand the anatomical relationships nearby. Other place to look where fluid can go, if I keep going further back down to here, the most caudal or inferior tip of the liver, that's a common place that we miss with our ultrasound where you find free fluid. Okay, now we're going to move on to the actual left upper quadrant view here. Here, this is appropriately labeled. We have head in this end and feet in this end. Again, it's still in a coronal plane. Our probe will be sitting in here. If you can see my phone sitting on the left-hand side of my chest. we should see something like this. This is not a wonderful ultrasound image, but what you should be able to see coming into view is something called the diaphragm. See this bright white line here? There's a little bit of an eye of face involved here, but there's like a curvy line there, and that's the diaphragm. Really important thing to see because that's going to help us separate what's in the thorax from what's within the abdomen. The big difference with free fluid on the left upper quadrant view is that you'll see, can you see the structure here? This is the kidney. You've got the spleen in there, you've got the kidney in there. This space here is very similar to Morrison's pouch. It's just between this big organ and this big organ. So this is the kind of the left upper quadrant equivalent of Morrison's pouch. This is the splenorenal angle. And one might think if the body was logical, you might find free fluid in there first, but you don't. Where you find free fluid in the left upper quadrant, the first place you'll see it is between the spleen and the diaphragm. So you tend to have to go a little bit higher with your fast scan and a little bit more posterior to get above and see that diaphragm, because that's where the free fluid is going to be. In this dissection video, let me just get it play. Here we have a little bit of stomach. We have a little bit of diaphragm has been cut away. This thing here, just what he's putting his fingers on, that's the spleen there. Can you see how far posterior it is? And where his fingers are, that's where free fluid will accumulate first within the left upper quadrant. So if you're scanning left upper quadrant, make sure you get above the spleen. Okay, left upper quadrant view. Again, a few more images just to illustrate it. We're going to have the probe quite posterior. And again, if you could see this compared to the other one, people describe it as knuckles are on the bed. When we're scanning the right upper quadrant, we use the liver as an acoustic window. And you'll hear about this lots tomorrow. The liver is a great structure for ultrasound. It's a big friend of ultrasound because it transmits ultrasound waves really well. And we can use the liver as a window to get our ultrasound waves through to other structures. The liver's massive, and it's great for viewing lots of structures on the right side. On the left side, it's a bit trickier because the spleen is really good at transmitting ultrasound, but it's much, much smaller. So we need to really hunt for a good window, and it's usually quite posterior and quite high to try and find the spleen. You're going to get an image, an anatomical image that will look a little bit like this. It's a coronal slice. You're going to catch a little bit of spleen. You're going to catch a little bit of kidney. But where we're really interested in is this little strip here, just between spleen and diaphragm. See my little ultrasound will come across. There we go. Here's the equivalent ultrasound image. Kidney down here, spleen up here. And notice we're not seeing free fluid between kidney and spleen. You can actually see it there. See that blackness there at the tail end of that image? That's free fluid between, as I said, diaphragm, which is just off screen, and spleen. And that's where you need to look for in the left upper quadrant. Here's another example, left upper quadrant. Here we have the diaphragm just there. Here we have the spleen. And then between spleen and diaphragm, lots and lots of free fluid. Let's have a look at our little scrolling CT slice. This is the front, so we can see ribs. We're now moving posteriorly. We can see liver. Liver is quite an anterior structure and goes all the way to the back, but we still have come all the way back and we still haven't seen any signs of spleen. There's the inferior vena cava. There's the aorta. Still can't see a spleen. We keep moving posteriorly, and this is the first appearance that we see of the spleen. So you can see how normally we'd be putting our ultrasound here for our Morrison's pouch. We're going to have to be, this is where our ultrasound probe would be. It's going to have to be a little bit higher and a lot more posterior to image the spleen. And what we're interested in, if we go all the way to the back, is not this area, but this area between spleen and diaphragm, just there. Okay, let's move on to the pelvis. So we've done right upper quadrant view, we've done the left upper quadrant view, and now we're going to move on to the pelvic view. Now, the pelvic exam gets tricky in the fast examination for two reasons. Firstly, we typically want two views. We'll want them in different planes. We'll want one in a transverse plane, so slicing this way, and we typically also do one in a sagittal plane, slicing this way. It gets even more confusing because the organs within the pelvis in the male and the female are different, and hence fluid accumulates in slightly different spots in the two examinations. Again, I'm trying to correlate the ultrasound with maybe a more understandable image of the CT scan. Here we have the inner sides of the pelvis. You can actually see the head of the femur bone just in there, and the head of the femur there. This structure has got a lot of contrast and neurons in the bladder, so I've got a nice big bladder here. This thing is a nice bit of poo sitting within the rectum, and a bit of feces. And this is what the ultrasound would look like. Fluid, just like liver tissue, conducts ultrasound really well, and so you see these glorious black fluid-filled structure. And it's really easy to see, and that's the bladder. See a nice bright bladder wall. Okay, so you can expect when you put the ultrasound probe on someone, and almost everybody will have some urine in their bladder, you'll be able to see a nice black fluid-filled structure. And what we're looking for, remember, in the fast examination is free fluid or fluid in the peritoneal cavity, fluid in the wrong spot. If we were to see fluid outside of the structure, that would make us worry about a positive fast examination. On the sagittal view, you're going to have head at this end, feet at this end. Again, this is someone who's now, they've got a sagittal view and they're fanning side to side. They're fanning through the bladder to see, can they see free fluid? Here's the equivalent image in the CT scan. Bladder in there, pelvic brim, and we're seeing limb scanning through. Difference between female and male pelvises, head at this end, feet at this end. The big difference is obviously you have the womb, you have the uterus sitting in there. Remember, fluid will always go to the lowest or the most dependent portion. So there's peritoneum coming down here. Here's the peritoneum coming all the way down. Behind the bladder. Remember, the bladder is an extra peritoneal structure. It's not within the peritoneal cavity. It runs over the roof of it and then doubles back on itself. This would be a great place for fluid to accumulate. However, in the female, the peritoneum goes straight back over the uterus and down towards the back. And here's a lower and more dependent portion. This area, the rectovesical pouch, the pouch of Douglas, the pouch of Douglas rectovesicles in the male, is where you're going to see free fluid develop. Let's see if I can get my slides to advance. There we are. Bladder at the front, uterus there, rectum at the back. Now remember, a lot of the large bowel is intraperitoneal, but it changes the bowel. Some parts of the bowel are retroperitoneal, like for example, distal parts of the duodenum or the sigmoid, and well, not all the sigmoid, but the rectum and the anus would all be retroperitoneal. So the lowest point that the fluid can get to within the peritoneal cavity is just here, otherwise known as the pouch of Douglas. In the male, things are a little bit different. You've got the bladder at the front. Yep, that's fine. You can see peritoneum coming over the top of it. But because there's no uterus in behind, the lowest point where the fluid's going to accumulate is going to be the rectovesical pouch. Again, because the rectum itself is retroperitoneal structure. Okay, so this is a more oblique three-dimensional view, again, of the female peritoneum. Peritoneum runs over the top of the bladder, runs back on itself, drapes over the top of the uterus, and the most posterior part is going to be the pouch of Douglas. In the male, for example, that's going to be the rectovesical pouch, free fluid. Notice this point here I've highlighted in blue. Can you see this point here? You can see the peritoneum reflect back on itself. So this is the lowest point that fluid should be able to get to, both in terms of it's the most posterior part, and even if you were standing up, this would be the lowest point that fluid could get to. You should not see free fluid in this area here. Free fluid in peritoneal cavity won't appear here. The reason, the relevance of this is your normal angle for ultrasounding through the male bladder. So you put the probe just on top of the symphysis pubis. Your ultrasound will go through the bladder. It'll go out the back. This is the rectovesical pouch here. This is the peritoneum coming down there, all the way through the rectum. So if you have free fluid in this area, it'll appear like this, okay? So we're taking our transverse image, so probe is up here, a bit of skin, lots of bladder with lots of urine in it, and then we're straight into this rectovesical pouch. And because this is a positive fast scan, there is free fluid just in front of the rectum, okay? If you were to angle too deeply down, so instead of angling across like this, you are angling through the bladder and then through this area that is not within the peritoneal cavity. What these things are here are the seminal vesicles, and they can give you a false positive scan because you can see how you could confuse this. You're still seeing bladder, and you're still seeing this black stuff that looks just like fluid, So just be careful with that. Seminal vesicles are often a false when people are first learning the fast scan. And again, you should be able to see this in your male models tomorrow. You should be able to see the seminal vesicles. If you angle too deeply into the pelvis, so if you've got the probe like this and you bring the tail all the way up, so you're angling heavily down into the pelvis, you'll start seeing false positives in seminal vesicles. Again, once you've seen it a few times, you won't mistake it. So where we see the free fluid, here's some examples. This is the transverse view, so a little bit of a view like this. Can you see this little black bit here? Okay, that is free fluid, usually off to the sides. Okay, that's where you're going to see the free fluid in the bladder, in the male pelvis. And then if you're doing it in the sagittal view, remember the peritoneum is going to come down here over the roof of the bladder. This is our rectovesical pouch here. So the sigma or the rectum will be down here. This is where fluid's going to accumulate. In the female pelvis, things can look a bit different. When there's lots of fluid, you get to see the uterus, and this is the uterus here. sitting in the middle, almost suspended by its ligaments, with bladder in front and free fluid in the pouch of Douglas in behind. Things will look a bit different again in the sagittal plane. But someone has helpfully dubbed this the TIE fighter sign, which I find quite entertaining. I don't see this little bit here, first there, and the wings up the side. Anyway, I thought that was quite memorable. It was dubbed the TIE fighter sign. Okay, we're going to move on and talk a little bit about the cardiac views. Now, part of my job, I do echocardiography. It's my big passion in life. It's by far the best use of ultrasound. Don't tell all the other people that, but it's by far the best use of ultrasound. In the cardiac views and echocardiography. Unfortunately, cardiac views are really, really hard, and they're really hard to describe anatomically because none of the planes that we cut the heart in are standard. So I was talking to you there about 3 dimensions. You could call this an X, a Y, and a Z dimension. You could call them sagittal, axial, and coronal planes. None of that really works for the heart because the heart doesn't follow any of the normal rules. It's not symmetrical. It doesn't sit in one, it's completely asymmetrical structure. It doesn't sit in the center of the chest. It's just off to the left. Even within the thorax, it's very twisted on itself. So we call it the right ventricle, but in reality, the right ventricle is better described as the anterior ventricle rather than the right ventricle because it sits very anterior. So being able to talk about it in terms of normal anatomical planes just doesn't really work. The other thing that's really difficult about cardiac ultrasound is that even if you could do it in normal anatomical planes, you can only image the heart where there isn't bone in the way. And that's different from all the structures within the abdomen because there's no bone in the way. Take a drink of coffee. Because there's no bone in the way in the abdomen, you can image it from wherever you want. But when you're trying to image the heart, it's enclosed in a little cage of sternum and ribs. And so we really have to take whatever window we can get. And so the images produced are determined not necessarily by the best way of imaging the heart, by wherever we can actually picture the heart. So it ends up being a real challenge to be able to understand anatomically these views and what they all mean. These are some of the more useful images that I found online. This is actually a plasticized pig heart. But it's a great teaching tool for showing echocardiography because you'll see this. If we've done any echo at all, this is the parasternal long axis. So this is the heart sliced down the middle along its longest axis. So if the heart, let's take my hand as the heart, it sits across, this is the long axis of the heart because that's where it's the longest. You'll have atria at the top, you'll have ventricles at the bottom. If you're taking a parasternal long axis view, you're slicing the heart down there. That's what this anatomical image represents: the right ventricle, the left atrium, the aorta, mitral valve, aortic valve. We can also take short axis slices of the heart where we take it in the short axis, in the narrow dimension. And we're going to get images like this, where we get the right ventricle, the interventricular septum, the left ventricular cavity, and then the anterior lateral wall there. Sorry. Let me go back one. The other difficulty with the cardiac ultrasound is that the whole thing moves really quickly. the liver and the spleen at least have the decency and enough sense to stay still while you're imaging them. But the heart is different again. That's what makes it so tricky because it's moving. You've got multiple structures moving at the same time. You've also got the challenges of respiration. Anybody that you're imaging for cardiac ultrasound is also breathing. And that breathing, as the diaphragm moves up and descends, the heart is going to move slightly within the chest. So everything is against you for doing cardiac imaging. So we're going to start with the subcostal view. And the reason we're starting with the subcostal view, it's one of the first cardiac views you learn as you do the subcostal view as part of the FAST scan. So I know we've moved on to cardiac ultrasound, but this is still kind of part of the FAST scan. The tricky thing with orientation in the subcostal view is that the probe is at the top of the screen. But this is actually, you're putting this just underneath the rib cage here subcostally. It's actually at the bottom of the patient. So the head of the patient is up here, the feet of the patient is down here, and you're imaging up the ways. But the actual ultrasound image is the opposite of that. You can see that we're using the liver. Remember I talked about the liver as an acoustic window. So we're using a lot of the left lobe of the liver here as a good way to send ultrasound waves through to approach the heart. In between the liver and the heart, of course, is going to be the diaphragm. This bright white structure here is going to be the diaphragm. So we're imaging the heart through the abdomen, and the ultrasound has to go through the abdomen to get there. Now, the heart itself, once you get the image, is relatively easy to understand because you're seeing all 4 of the chambers in the same image. You've got a nice left ventricle right ventricle. You've got a left atrium and a right atrium there. Okay, so you're seeing all four chambers: left ventricle, right ventricle, left atrium, right atrium, left ventricle, right ventricle, left atrium, right atrium. It's kind of easier to get your head around when you can see all four chambers in one view. This is the apical four-chamber view. This view is obtained at the apex. So you all learned in medical school, I hope, where the apex beat is. So you find the apex beat. It's usually fifth intercostal space, followed out towards the nipple line. Somewhere around there, you're going to find your apex beat. Wherever you find your apex beat is the best place to put your ultrasound probe. And here in this one, you're trying to image up through the four chambers of the heart and image that one. And you're going to get a lovely view again where you can see the four chambers and the atrioventricular valves all in one view. Left ventricle, the bigger one, right ventricle, the smaller one, left atrium, right atrium, and the fluttery, flappy things in between are the atrioventricular valves, mitral valve on the left hand side, and tricuspid valve on the right hand side. Okay, that's the apical four chamber view. The parasternal long axis view, I think, is the view that I found it took me the longest to understand and orientate myself anatomically. The imaging plane for the parasternal long axis view is diagonally across the chest. So if this is my probe, I'm taking diagonally across the chest with the probe marker towards my right shoulder. And we're trying to take a long axis, a slice of the heart along that direction. And you're seeing lots of structures in the heart in the same plane that you wouldn't expect to see together. So, for example, we're seeing the mitral valve and the aortic valve in the same plane. We're seeing the left atrium and the left ventricle and the aorta, but all we're seeing is a little bit of the right ventricle. So it can be a little bit confusing to get your head around when you first look at. Again, I'll point it out in the ultrasound image here. We've got the ascending aorta here, and we have the descending aorta down here. So we're actually catching two completely different parts of the aorta in the same image. We've got the left atrium, blood comes into here via the pulmonary veins. It then moves through the mitral valve into the left ventricle. In the left ventricle, then it's ejected through the left ventricular outflow tract, through the aortic valve, which you're just seeing here, into the ascending aorta, where it will loop over the arch of the aorta and eventually end up coming towards the screen in the descending aorta. You also catch a little bit of the right ventricle in the parasternal long as well. Now, the next view you go to from the parasternal long, remember the parasternal long axis, the probe is sitting in this direction, with the probe marker towards the patient's right shoulder. The next one we're going to do is the parasternal short axis view. And the parasternal short axis view is 90 degrees to the parasternal long axis view. So now instead of the probe marker being towards the patient's right shoulder, it's towards the patient's left shoulder. Everything that you see along this dotted line here, okay, when you turn that probe 90 degrees, you're going to see every structure along this dotted line. You're going to see the wall of the right ventricle, a little bit of right ventricular outflow tract. You're going to see the interventricular septum. You're going to see the LV cavity, and you're going to see the posterior left ventricular wall when you get a parasternal short. This is the parasternal short axis view, and you're going to see, can you see that little dotted line I took? I can see a little bit of right ventricular wall, RVOT, interventricular septum, left ventricular cavity, a bit of mitral valve, and a bit of the inferior wall there. So the parasternal long axis view, short axis view, you're just going 90 degrees, and everything that's in the middle of this parasternal long, you will see on the parasternal short axis view. So this is just this view, but turned 90 degrees. Again, this will make much more sense once you have a probe in hand. Looking at it again, using our little plasticized pig model, left atrium, left ventricle, aorta, right ventricle. Okay, left atrium, left ventricle, aortic valve, right ventricle. Okay, we take our little line. That's our rotation line. That's where we're flipping this image. We're looking at it this way, and we're going to turn it 90 degrees. When we turn it 90 degrees, we get a slice. This white dotted line here, we take a slice through the heart, and we look now down into that heart, and we've got right ventricle, interventricular septum, left ventricle, posterior wall. Okay, right ventricle, interventricular septum, left ventricle. Okay, I'm going to talk a little bit about arterial supply to the heart. And why that's important is that heart attacks are really common and a really important emergency to pick up. Obstructions to the coronary arteries are really important that we diagnose. So if blood stops flowing to any given section of myocardium, of the heart muscle, then the myocardium will struggle to contract. And that's actually something you can see really nicely on echo. Remember all those images I've showed you so far? You're seeing two walls of the heart that are squeezing away like this. Let's say we lose the blood supply because there's a blockage in a coronary artery because of a heart attack to one wall. All of a sudden, one wall isn't moving. And you can imagine you'd be able to see that really well on an ultrasound scan. And you can. You can see this on an electrically as well. So that's probably the earliest sign, and that's the way you're going to diagnose most of your heart attacks. It's going to be on an ECG. So when a coronary artery is occluded, and depending on what artery is occluded, is going to cause different patterns of stuff called ST elevation. Now, I have no idea what stage of your training is at, but this is a very scary looking ECG. So there's lots of ST elevation in the inferior part of the heart, and that corresponds to the right coronary artery or the left circumflex being occluded. If you have lots of ST elevation in this area, it will be more consistent with a blockage of the left anterior descending. So the ECG is critical in kind of working out where the blockage in the coronary artery is. Now, obviously, this is not ultrasound. This is not what you're here for. But you can't, all of those same things that you do with the cardiac ultrasound, in other words, you can localize which artery is blocked with ECG. You can also do it with echo, because each of these segments of the myocardium is supplied by a different artery, and they're all nicely color coded for you here. These are not my images, but they're excellent teaching tool, I find. So if you're looking at the heart and you're seeing that this area is not squeezing as well as this area, then it's much more likely to be the right coronary artery, the circumflex is the artery involved. Now, as a take-home clinical point for when you're a doctor, the ECG is a much, much more important test to be doing if you think your patient is having a heart attack. Do the ECG first. That's number one take-home tip. Do the ECG first if you want to pick up a heart attack. But again, once you start practice, you'll realize that a lot of ECGs are what we call non-specific. They're not diagnostic, and you're left with this conundrum that you still think your patient's having a heart attack, but there's not enough evidence in your ECG to prove it. Very often you'll find us doing echocardiograms to help give us a little bit more information. Can we see, is one section of the heart not beating? And that would support the diagnosis of a myocardial infarction, a heart attack. It might lead us towards doing an intervention to open up one of those blood supplies. Okay, I'm going to talk a little bit about the mitral valve. This is an atrioventricular valve, so it's a valve that allows one-way flow from left atrium into left ventricle. It's really important that blood flows through the heart in a one-way manner. If blood was to move from the left atrium into the left ventricle and then move straight back into the left atrium, you would run into big trouble very quickly. And that can happen in mitral regurgitation when there's problems with the valves, and patients get really, really sick when that happens. It's got two leaflets. They are cleverly named the anterior leaflet and the posterior leaflet. So that makes them fairly easy. One's more anterior than the other one. And the mitral valve opens when blood moves from the left atrium into the left ventricle during the period when the heart is filling, called diastole. When the ventricle then goes to squeeze out blood, so once the left ventricle is completely filled, it wants to squeeze that blood out through the aorta. The mitral valve is cleverly designed that when fluid comes against it, it snaps shut. Okay. And it's like a little bit, it's got these little parachute ropes at the bottom called the chordae tendineae, or the heartstrings that are attached onto papillary muscles. That stops the valve from turning inside out. These little strings that run from the tips of the mitral valve to stop it from turning inside out. On ultrasound, you'll find the anterior leaflet is the bigger one. Again, it's all divided into various little cusps that you don't really know about. You can have various different parts of the mitral valves that are certainly beyond the scope of this talk. I think it is useful to be able to difference, to be able to identify which is the anterior and the posterior mitral valve. The aortic valve is fairly easy to visualize. So this is a parasternal short axis view. You'll notice it looks a bit different than our usual one because we're not seeing the left ventricle. When you take the parasternal short axis view, remember we're taking a slice with the probe marker towards the patient's left shoulder. You're taking a slice through the short axis of the heart, and you can take that slice at various levels. If you're slicing a loaf of bread, you could slice here, here, here. This is a slice quite high in the heart. Okay, and we're going to take a high slice. You'll see these structures. You're going to see the aortic valve. You're going to see lots of the right atrium, tricuspid valve, most of the right ventricle. You're going to see the pulmonary valve in there that will go down into the pulmonary arteries, and you'll see the left atrium. The aortic valve is quite different from the mitral valve. It's three cusps or leaflets. We'll talk about their names in a second. Those cusps are self-supporting. They don't have the parachute ropes or the strings that the mitral valve does. And these aortic cusps, aortic valve leaflets are named for the coronary arteries that come off them. So you'll see there's a left coronary cusp, a right coronary cusp, and a non-coronary cusp. Oh, I need to go back. I went through that too quickly. The you can actually see this structure here. They're named for the coronary artery that comes off them. So the left coronary cusp is named for the left main coronary artery, which becomes the LAD. And you can actually just see it on your ultrasound, and you should be able to see this tomorrow. If you've got good views, you can often actually visualize the left main coronary artery. The right coronary cusp is named for the right coronary artery, which is going to be coming off just in here. And the non-coronary cusp is named because it doesn't have a coronary artery. What types of pathology might you see on an aortic valve? One of the commonest things you'll see in older people will be calcification. So this is our parasternal long view. You've got your left atrium, anterior mitral valve leaflet, posterior mitral valve leaflet. Blood moves from LA to left ventricle, and then blood is ejected through into the aorta. You can see this aortic valve. It's very bright. Can you see it's really bright compared to the other structures? It looks very thick. And that's a heavily calcified aortic valve. Calcification, I know it's calcification because it has shadowing. So when your aortic valve gets calcified, it acts a little bit like bone to ultrasound. Ultrasound reflects strongly off it and does not pass through it. So you can see deep to this. If you look beyond the calcified valve, you can see there's a shadow where the ultrasound doesn't pass through. And as the valve opens and closes, that shadow moves across as well. Okay, finally, for a few minutes, I'm going to talk just very briefly about thoracic ultrasound. If I'm going on too long, feel free just to unmute and tell me to shut up. I'm very used to that. We'll talk a little bit about thoracic ultrasound. Let's say you're dealing with someone with left-sided pleuritic chest pain. And by pleuritic chest pain, I mean it's pain when they breathe in. It's sore when they breathe. And let's say it's on the left-hand side of their chest and they're breathless. When you listen with your stethoscope, there's less air entry on the left side. You're hearing less breath sounds on this side than you are on the other. And you're worried. What are you worried about? We put an ultrasound scan on and we get an ultrasound image on the right and an ultrasound image on the left. And we'll come back to those in a second. What we're looking at in the lung ultrasound, there's a few things we look at, but primarily looking at pleural sliding. So this shimmering effect that we can see here, can you see this little bright white line here? I've heard that described as lots of little ants marching up and down, or a shimmering is a good way to describe it. Those are the two layers of the pleura sliding over each other. So the parietal and the visceral pleura are sliding over each other. And that tells me that the visceral pleura, which lies adherent to the lung, the visceral pleura lies on top of the lung tissue, and the parietal pleura, which lies attached to the inner aspect of the chest wall, that shining tells me that those are two surfaces are in contact. And that's a really good thing because that tells me at that area there is no pneumothorax. And in pneumothorax, the layers of pleura will separate. The visceral and parietal pleura become separated and you will lose the sliding on that side. Now, the other thing that's important about doing this ultrasound scan, you can see these structures here, one kind of oval shape, one here, and a little bit of that one there. Those are the ribs. When we're taking this scan, it's typically, we're in a sagittal plane now. We've got the probe resting on the ribs, and the probe is usually wide enough to capture a couple of ribs. The reason capturing the couple of ribs is important is that there's a whole bunch of white lines here running all the way across. And how I know this one is the pleural one is that the bright white line that's immediately underneath the ribs is the pleural line. Now, when I've taught ultrasound before, I find that a lot of people identify the pleural line by looking for sliding. Okay, they look for sliding and that's how they know it's a pleural line. The difficulty with that kind of logic, however, is if there is no pleural sliding, how are you going to identify which line it is? So that's why it's really important that you position a rib on either side when you're doing your ultrasound. That way you'll know the bright white line that is immediately underneath those ribs is the pleural line, whether it's sliding or not. And that'll really help you when you want to diagnose a pneumothorax. Last thing I'll say about pleural ultrasound as well. See all these other bright white lines here? These aren't real. Okay, this is the machine making stuff up. So a lung ultrasound is a lot about interpreting artifacts. And by artifacts, I mean funny little kind of idiosyncrasies of physics that occur when ultrasound waves hit a very bright reflector. This is all muscle. These are tissue planes. These are ribs. These are all real. Everything you're seeing there is real. Everything below the pleural line The machine doesn't know what to do with the sounds that's being reflected from this line to the probe, and the machine gets confused, and it tells you that there's things down here when there isn't. The interpretation of those artifacts, so those interactions of when the sound waves hit the pleural line, is what we do for most of lung ultrasound, and those artifacts are actually really useful. Just to illustrate the pleural cavity as well, so the pleura extends throughout the thoracic cavity. It curves over the diaphragm from a high point all the way up at your xiphisternum to a low point all the way down towards maybe the 10th rib. So it's got a huge extent throughout the thoracic cavity. And if we go back to our original patient, remember this is a patient who had pleuritic chest pain. So on their, and we said, was it on their left side? Let's say this is the ultrasound image of the affected side. You can see we've got lovely pleural sliding on the normal side, and we've got no pleural sliding on this side. We can see our rib here, so I know the pleural line isn't sliding anymore, but I know it's the pleural line because I can see my rib in there. So this tells me that what has happened is the parietal pleura, marked in yellow, and the visceral pleura, marked in red, have become separated from each other. On this side, for example, the visceral and parietal pleura are nicely in contact and rubbing off each other, so we've got lovely pleural sliding. On this side, we don't. And here we have a pneumothorax. For further correlation of this one, this is a thoracoscopic view, so it's a bit like laparoscopic surgery. You can put a little camera inside the chest. These are ribs, 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 and this is lung, and they're actually picking up the lung and having a little look around it. So the lung here is all collapsed. Parietal pleura over this, visceral pleura over the lung. If you were to do a lung ultrasound from the outside right now, you would have no pleural sliding, just like this. There's a little rib just over here, then the bright white line immediately deep to the rib is the pleural line, and there is no sliding. And in this area, you'd say there's the pneumothorax. We also use thoracic ultrasound to look for fluid. Here's a lovely image of the left hemithorax with a large pleural effusion. You image this, you can see we're using the curvilinear probe rather than linear probe. And this is actually just your left upper quadrant fast scan. Remember, our left upper quadrant fast scan was a coronal view, and all we've done is move it up. It's exactly the same thing. We've just moved it up above the diaphragm. This is spleen. This is diaphragm. All this black stuff is fluid within the pleural cavity. And this little flappy thing here is collapsed lung. So this is lung that used to have air in it, but it's been squished down because of all the fluid that's around it. Again, the analogy here is we're going to flip this sideways. We're going to put our ultrasound probe here. If we were doing the fast scan, the probe would be down here, looking at the fluid between spleen and diaphragm. But we've actually just moved a little bit further up towards the head. And this is the image that we're going to get if there's a large pleural effusion. Once we find fluid, ultrasound can be really useful to help us put a needle in it, put a plastic tube in it, and help us drain it. And one of the concerns about putting needles in the chest is typically to do with the blood vessels that lie nearby to the ribs. Now, you were all taught in medical school that these lie in the neurovascular bundle, and that's nicely hooked in there, nice and safely underneath that rib. Okay, that's where you find the neurovascular bundle. So if you aim in the lower part of that space, you're going to avoid the vessels entirely. Unfortunately, patients do not read textbooks and decide, and in real life, blood vessels go wherever the hell they want. This is a nice CT scan study where they injected contrast into the arteries to make the arteries show up nicely. And you can see this is a rib here. The white thing is rib, white is rib. This is the space between the ribs, and you can see that the arteries are just going do 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 wherever they want. And if you put a needle in there, you may well hit a blood vessel. Same thing, we have an anatomical study here where they've put ribs here and a rib here, and you can see in little yellow pins there are blood vessels running right the way through the middle of the intercostal space. So as such, it's not a bad idea to use ultrasound to see if you can see them. So again, we would expect the neurovascular to be somewhere bundled to be in here. You can't actually see it just with ultrasound, but we can use a thing called color Doppler that can actually look at blood flow within blood vessels just to see, is there a blood vessel peeking out from behind the rib. So in this example, there's a clear blood vessel at the lower aspect of this rib. So I'd probably want my needle to come in somewhere here so I avoid putting a hole in that blood vessel. Okay, so we've gone through the fast scan and we've gone through cardiac ultrasound and thoracic ultrasound, and hopefully you'll be able to relate some of the anatomy that you've learned in med school so far to your ultrasound images that you're going to see tomorrow. And happy scanning. That's me done, and I shall stop sharing.
Thank you so much for your lecture, Andy. It was very interesting. Are there any questions from the audience? Yes, please. 1 second.
Hi, Nan. Is that
Yep, can you hear?
The microphone is not working. Oh, wait.
My question is, if you happen to find a patient with a retroversed uterus, would you still expect the fluid if you have some in a Douglas pouch, or?
Yeah. So obviously it's quite common for people to have retroverted uteri. So instead of flopping forwards over the bladder, they're tilted back the ways. You would still, just because the uterus is turned back, there'll still be that same, the peritoneum will still fold in behind it, even if it's pointed backwards. So you'll still expect to see it in the same place, as far as I know. I don't think I've ever seen that, but as far as I know, it should.
Thank you. Any other question? Okay, then I have one question for you as well. How has ultrasound transformed emergency medicine and intensive care routines since your time as an assistant?
Okay, so I graduated from medical school in 2004, so I've been a doctor almost 20 years now. When I first started, ultrasound was a very rarely done. It was only done in the radiology department, and it was done for things like diagnosing gallstones and things like that. There was no use of ultrasound within the emergency department or within intensive care. So when I first started intensive care training, 2006 maybe, I learned how to do central lines, so into the internal jugular, into the subclavian vein, primarily by we now call it blind, but it wasn't blind. You didn't have a blindfold. It was the landmark technique. So you had to know your anatomy. You had to know that if you put a needle in this direction, you will probably hit the vein rather than the artery. But there were lots of times that we hit the wrong vessel. We put holes in lungs and we did lots of things. So ultrasound came in the most popular use, certainly within Ireland and the UK in that scenario, probably around 2008. It would be unthinkable now for people to put in, not unthinkable, but it's very, very uncommon for people to put in central lines into the big blood vessels in the neck or in the groin or anywhere without using ultrasound. So that has transformed emergency medicine, intensive care, cardiology, all the cath lab procedures. In order for them to get access, that's all into their arteries or veins is going to be done. Interventional radiology, all kinds of procedures. So procedurally, it has transformed things because it's so much safer to just watch your needle going into the structure that you want to put your needle into, as opposed to just keeping going until you hope you're in the right place. So procedurally is one. Diagnostically, I find it's transformed, and I'd say this is more the intensive care side of things, is the echocardiography thing. So that most of my job is intensive care. We do a lot of cardiac surgery, cardiac transplant, stuff like that, a lot of ECMO stuff, all that. Trying to look after someone who's really sick and hypotensive and really severe shock without knowing what their heart looks like is impossible as far as I'm concerned. I just don't know how you do it. Ironically, the one thing where ultrasound has not made any difference to my practice is the fast scan. So the original scan that was developed, which is the first scan I ever learned, in modern trauma practice, I actually don't know if the fast scan has that much of a role. Because what you really need when you're dealing with an injured patient is you need a CT scan. You need to know all of the details on CT. And so in many ways, it's the one place where I actually don't find ultrasound that useful is the fast scan.
Okay, thank you so much. Thank you again for your insightful lecture. We appreciate your time and the value of your knowledge you shared. It really means a lot to us that you join us for the third time.
Pleasure. Thanks very much.
And as you're aware from the past, your gift is on its way to you.
Excellent.
We hope you like it. Yes, let's give another round of applause for our fantastic lecture.